we've talked about who requires the first biopsy. If you've got a negative biopsy, given the fact that, again, there may be tremendous undersampling due to our current technology limitations, who might require a rebiopsy. And then we get into this category, which again I think is very important, is to aid us in better risk stratification. Really, so if you have a positive biopsy, people want to know, number one, do I need to be treated? Will I die of my cancer? Am I a good candidate for active surveillance? Those types of things. So, Brian, what's currently out there in terms of giving us better risk stratification for our particular patients?
You know, my impression is, as urologists, we have really not much difficulty diagnosing prostate cancer. I mean, when we do a biopsy, I think we're doing a pretty good job, and maybe multi-parametric MRIs will get even better at it. But now we got this challenge. You diagnose a man with prostate cancer, now what do you do? And there's a lot of pressure to, you know, have a program of active surveillance and trying to triage these patients, who needs to be treated and who doesn't. So you have two different genetic tests, the Oncotype DX and the Prolaris, both looking at different gene factors and really just trying to push that needle from what we always have understood with Gleason score and PSA levels and number of biopsies positive, who should be treated and who shouldn't. So now you're trying to decide, is this more aggressive than we would have expected or less aggressive? And sometimes I think that helps the discussion with patients of who should be treated and who can be more safely watched. So both of those tests we've used. I'm still trying to sort out for ourselves in Oregon Urology which ones work best for which patients, but that's the category of those genetic tests. And then for those patients who go on to have surgery, a radical prostatectomy, there's the Decipher genomic classifier, which is looking at 22 different markers and what's the risk of biochemical recurrence, development of metastases. Maybe those are the patients who may need adjuvant radiation or other therapies after surgery.
Yeah, so, yeah, again, different endpoints for 3 different assays, all sort of in the same area. So we know that Prolaris, which is from Myriad in Salt Lake City, their endpoint was what's the likelihood of the patient dying of their disease. And now the Oncotype DX, the GPS, which again is from Genomic Health, their clinical endpoint is what's the likelihood of them harboring unfavorable pathology. So whether that be a higher Gleason, which we know about 20 to 25% of patients potentially do get upgraded, and what's the potential of them having even extracapsular disease. Those are kind of the 2 categories that they put in there for of unfavorable pathology. Now, the folks at Genomic Health, they also, though, presented an abstract recently at ESMO. And Ganesh, can you walk us through that a little bit?
Yeah, sure. And I think you really bring up a good point, but and something that folks who are looking at this kind of cornucopia of biomarkers and trying to sift through what to use when, is we're looking at the endpoints and trying to get a sense for what is this biomarker predicting precisely and what study, what it was done. As you said, the Oncotype DX study by Genomic Health, their primary data was with regards to adverse pathology. And as you rightly said, there are many men, even in the high-risk category, who never fail, who never recur, who never develop metastasis. With prostate cancer-specific mortality for someone with D'Amico high-risk classification after radical prostatectomy is almost only like 40, 50%. 50% don't die of disease at 10 years. Suggesting that there's a lot of heterogeneity. Ironically, that's the exact space where the Genome DX place has a biomarker. So you have one biomarker predicts something that another biomarker then predicts something after that. So I think trying to get at that, the Oncotype DX is trying to, I think, look at a very meaningful endpoint here, like you said, in terms of outcome. And so what they did was publish it at ESMO, as you said. They prospectively looked at their 17 genomic gene signature and looking at biochemical recurrence and metastasis. And this was in approximately 431 patients treated with radical prostatectomy with either NCCN guideline very low or lower to intermediate risk prostate cancer. Bottom line is they found that their 17 gene genomic signature was predictive of biochemical recurrence on univariate analysis as well as metastasis, but their multivariate analysis didn't include some of the usual suspects. Interestingly enough, their multivariate analysis didn't include Gleason score. It included some other things, but it didn't include Gleason score. It's a small study. I will say the study did include African American men. In fact, 21% of their population included African American men. I think this is moving in the right step forward in terms of trying to evaluate this biomarker and its ability to predict meaningful outcomes. But of course, it needs to be validated, as we talked about before, in larger populations and by different groups.
Yeah, I mean, I think it's pretty clear that, you know, if you think about what we do and when we counsel patients, when we talk to patients about prostate cancer, all the data that we cite, because that's what we have, is basically population-based data, whether it be from a single institution versus, you know, large trials. And I think patients, you know, really want to know. That's great, but what happens to me? You know, what happens to me? At the end of the day, the patients want to know what happens to me. And I think we all need to be cognizant of the fact that, as everybody has said, there is a lot of heterogeneity in this disease. And obviously, every person's different. Everybody's immune system's different. Everybody's, you know, genetic codes is different. So this is, again, you know, going into the right steps. So Ken, you're